Good.
Okay. So looking at knees and ankles in varying positions, as always, there's trade-offs. Seated is not as good for the knee. As you can see, the knee is hanging directly over the table in a relative flex position. So if I try to generate flexion, I run into the table. There's really nothing I can do about that. I can generate way more hip flexion so I can close it, but it's just awkward. So hip or knee extension, fine to test. Knee flexion, difficult to test. I can test the rotations. The ankle is much more accessible to me because it's going to be quite free and I can stabilize the shin. So relational motion, I can hold the shin still and move the ankle. So I would do that sitting. So again, just to show what I mean, I can't test that. Even if I do this, I can't test knee flexion, okay? I can test knee extension, relatively speaking, right? So we get some resistance there, you agree? Like I could make it go farther, yes, but it's not nice. I can check rotations, but look, if I'm not careful, I really can't, right? So if you look at the patella, right, this is a moving thigh, right? This is a less moving thigh, but I'm not doing a good job. I'd have to stabilize up here so the patella doesn't rock around. So if I wanted to check rotations, I'd do it here. As far as the ankle is concerned, is that in closer? No real concern here. Dorsi, plantar, inversion, eversion. No big problem. I can work the foot here quite well as well. I can assess the foot. So it's quite free to move in the plane or planes required. I can stabilize the leg, the shin, whatever term you prefer, and I can move the tarsals. So tarsals, right? I can even hold the calcanea still and move the tarsals in relation to it, right? So lots of options for the foot and ankle in seated, very restricted options for the knee. If I go into lateral, we end up running into the same problem as I can check one knee and one ankle, but I can't compare them. I have a problem there. If you are comfortable, we'll have you lay on your back with your head up there. Well, oh, you're doing a great job. Thank you. You're sliding the pillow out. Thank you. So the knee, right? I clearly, if it's on the table, I cannot flex it. I can extend it so I can check overpressure. So now this doesn't feel as bad with extension as in seated because it changes the position. So I can really kind of check if the knee will fully extend because the leg is a lot more relaxed. I can check my rotations here, no, right? But again, it's hard to see. I'm really likely to let the patella move, so the thigh is going to move, right? Almost no matter what I do. So it's not actually as easy. Knee flexion, very free here, right? And I can palpate around, see what's going on. The thing that stops knee flexion almost for everybody is soft tissue approximation. So the calf hits the hamstring. That's what stops it, right? So it's not often as meaningful unless it just doesn't even get there. You will definitely have people who don't get there, people with sometimes tears, but not always, and then knee replacements, right? So knee replacements are going to be your problem. As far as checking, what's that? Oh, I swear I heard something. But then rotations, I can check them better here, right? Because now the patella is not rocking all over the place, the thigh is not moving. The ankle in supine, I can check up here, right? As long as I've got good contact and control. This is probably going to feel better. This feels better when I do it this versus this, right? So there's just more control here. But I'm in an awkward position now. And if somebody was taller, based on the size of my forearms, this isn't going to work great. So the ankle is obviously nice and easy to check. Here, I can sit, I can stand. Dorsi, plantar, inversion, eversion, still shin, moving tarsals, right? I can, relatively speaking, check them against each other, but once I go to this, I run a little bit more risk of this. It's not bad because the table is going to stabilize that quite well, right? So if I was going to choose a foot, it's this foot. You agree? Right? If I was going to choose a foot just right there, now I know, right? It's really more or less the same thing in prone. It's just a bent knee, right? Checking the knee in prone, we'll have you lay on your stomach. So I'll actually show this instead. Please excuse. Oh, don't worry about it. That's okay. So, right, that's as extended as it's going to get. I can check flexion, no issues. What you're going to see, though, is when you bend the knee, you'll often see the pelvis roll. The interpretation of that, you can make a lot of assumptions, but realistically what the easiest thing to suggest is there's something on the front of the thigh. There's something on the front of the thigh that has tension in it. Some people will tell you if in a certain amount of degrees the pelvis rolls, it's the quad. If it's higher, then it's the psoas. I'm not sure I buy into that on account of the fact that I can't really observe either properly. I just know that when I bend the knee, the pelvis starts to roll, right? So I can test it all the way, right? But I'll get to soft tissue approximation. Is it Apley's in here, right? Apley's compression, and then you grind it. But I can really get a good idea of the rotation of the knee, the minor movements here, right? Since the thigh is well supported, it will stay quite still, especially if I block on the thigh or on the femur, and I can palpate on either side of the knee with a yoke. So I really get a good idea there. As far as the ankle is concerned, this actually becomes a little bit more awkward because I can't really see it. All I see is the bottom of the foot, right? So this, I can feel resistance, but I can't absolutely tell what the heck is going on. And then I have to change my hand. I'm not going to check inversion and eversion here particularly well because I'm going to get a lot of deviation. I'm going to get it better here and here because I can really control it. So what you'll see is it'll do this, right? So I can control better if I hold differently. So the ankle is quite accessible in almost all positions. It's really, really awkward in lateral. It's really awkward, but it's quite accessible because I can get it away from the table and I can keep everything relatively still. I can control the leg or the shin quite well with my hand in most circumstances. But really, again, to try to figure out which one I'm concerned about, supine is really easy, really accessible. I can check them against one another really quickly and just figure out which one I'm concerned about quickly. Same thing with the knee, actually. It's probably quickest to figure out which knee I would be concerned about in prone because I would just do that. Right? Which knee am I concerned about? There you go. Right? Because I can do it bilaterally. It's quite safe. I don't have high requirements for stabilizing it because it's quite safe. So figuring out which knee is the biggest problem is probably easiest in prone. But to fit that into a normal assessment process becomes a little bit awkward. So you have to have a reason to check the knee. The person will tell you that you should check the knee because they're complaining about it. Good.